Alright, so we're going to go ahead and get started with the content. So this week's information is going to be chapter 41. I printed off a new schedule for you guys because I had some dates and chapters mixed up, but I forgot them on the printer, so when we go on break, I'll go get them up here to you. I reposted a new calendar in 245. I've not fixed 247's calendar yet. But the content that we're going over this week is going to be management and resuscitation of a critical patient. There's a few things in here that I want to talk about. We're not going to get like really in-depth into critical care or anything like that, but it's going to be more or less steps we need to take. And really there's going to be a lot of stuff about your attitude and your competence in taking care of critical patients. But after this, we'll start on neuro and cover stroke. And at some point, I'm going to do the EMSA training with you guys. I know a lot of y'all have probably already done it with your ambulance service, but I need to go over it again. And then there's going to be stuff from pulmonary. Now, the thing about it is that Richard went through airway and pulmonary diseases with you guys back last semester. So since I have tomorrow kind of taken from me with the EMS challenge, I've got to get through chapters 41 and then chapter 19, which is neuro. And then if we got time, we might look at some pulmonary stuff. But if not, we're going to have to move on, okay? All right. As far as like the PowerPoints go and all that, since this is the first time that I've taught the class out of the new book, so I'm having to update stuff as we go. I just simply don't have time to update everything before class starts. And so when you look at files and download PowerPoints or whatever, just know that I may put the new stuff up before class. And so it's going to all be very similar, though. There's not a lot of changes in the book that you guys have and in the book that we were using. But are there any questions before we move on? All right, so we're going to be looking at critical thinking and decision-making abilities in the first few slides here. And the thing is that this is why you train as paramedics. The critical patients are why you train as paramedics. For those of you that are working on the ambulance full-time, don't get cynical, because there's going to be those patients that abuse the system. There's going to be those patients that just simply don't need BLS or ACLS, ALS. But for those that do, this is why we have to spend the time training, right? And so you've got to be able to kind of put yourself into that mode, that critical thinking and critical care mode, because when you go from taking care of Miss Alice's tote here to a pile up on the interstate with multi-system trauma and shock or a cardiac arrest or whatever, you're putting your body through several different sensations, and you're activating several different areas in your nervous system, and it can be very taxing and very tolling on your body. And so one of the things that you've got to do is start working on experience and working on critical thinking, so that when you get into those critical situations, you can work past what's called the catecholamine dump, and get that pit in your stomach, or that feeling whenever the tones drop and it's a really bad sounding call or something like that. And that's the catecholamine dump. Your sympathetic nervous system has been activated, and you've got epi, norepi, dopamine, serotonin, all these things flooding your body. And we've talked before about what the sympathetic nervous system's there for, right? It's there for the fight or flight. It's there for a protective mechanism over your body, right? But the thing about it is that when it developed, it was that we were looking for that one saber-toothed tiger we had to defend our family against, and not everything else around us. Okay, it is a can't even think of the term I'm trying to use, but it's one of the your sympathetic nervous system is probably one of your earliest developed systems in the body, okay? And not much has changed in the sympathetic nervous system as evolution has occurred, or as people have evolved from, fighting saber-toothed tigers, and I'm just making that up, but, from the times where they had to just defend their family from a local threat, and where they got very much tunnel vision, to where we're having to adapt to handle a lot of things at one time, okay? The question always goes for me, do we diagnose in the field? And the answer is yes, we do. All right? You have to form a field diagnosis. How do we get to that field diagnosis? Is through our differential. Okay? We're going to talk a lot about our differential diagnosis in medical emergencies, because there's a lot of stuff that can go on that we've got to figure out. We've always thinking of the worst case scenario in our mind, right? But we're also trying to work through the easiest things. For instance, you've got a patient that's unresponsive. Worst case scenario, I don't know, maybe a stroke or something like that. But one of the easiest things that we can check on them is a blood glucose, right? And so we're always trying to form those diagnoses in the field and kind of do a mental scratch out of them, right? Okay, well, I checked his blood sugar and it's 110, so I know that they're not hypoglycemic, so I need to move on to the next thing. The reason why we have to form this field diagnosis, though, is we have to figure out a treatment plan in our head, all right? I'm making a lot of things sound really complicated here, but that's really what you're doing, okay? When you decide, okay, I think this patient is experiencing X, Y, or Z, and because they're experiencing X, Y, and Z, I'm going to go down this pathway to treat them. You've now formed a field diagnosis, and then you are working your treatment. Now, we know that in the field with critical patients, they're dynamic, right? And we may discover something along the way that we didn't have at the beginning of taking care of that patient, and now we may need to adjust our treatments a little bit, okay? But you've got to be able to adapt. You've got to be able to work in a situation where you can do a quick assessment and realize and remember what you need to look at. Remember, it's not always just going to be the BSI scene safe number of patients, whatever. We've got to work through that quick, that primary assessment, into that secondary assessment, okay? When we're out working with critical patients, it's not just a linear check sheet, right? It's not just a check sheet. It's going to be dynamic patients that we have to work our clinical thinking around and to form diagnoses. You got to be trained to make the right decision, to use your time appropriately, and to provide care. And there's a lot more that goes into that than just thinking, hey, I'm going to make the right decision, or I'm going to use my time appropriately. Okay? What I mean by that is simply the fact that there are a number of things that we're going to go over this semester in medical emergencies. We're going to go over a lot of disease processes that look exactly the same. We're going to go over a lot of things that are very similar in nature but could have some big consequences if we weren't able to identify them. We're going to go over some disease processes that are what we call low frequency but high criticality. What do you think that means?
Kill them very easily.
Yeah, we don't see it that often in the field, but for that patient that is experiencing it, it could be very critical for them. And that's something that affects not just in EMS, that affects a lot of, especially acute care providers, nursing and things like that too, because you get so bogged down with these same old things over and over and over again that you almost get to the point, like I mentioned earlier, where you feel like you're getting cynical. And once you get to that point, then no patient is really going to be serious to you. And then you're in a big handle there, because that one patient's going to be sick, and you've got to be able to determine, what's going on with them. If they're in critical condition, you got to be well trained to make the right decision. That's one of the reasons why we do scenario after scenario after scenario. That's why one of the reasons why we do these situations where it puts you under high stress. All right. It's one of the reasons why we do collaborative lab or MCIs or whatever, is to put you under high stress. Because I'd much rather you be under a high stress situation where there's low stakes involved, meaning you can't kill a mannequin any deader, right? I'd rather you be under that situation while you're training, so that as your training progresses and you get into the field, then you can start adapting to how you treat those patients, okay? Because could you imagine the first time that you worked a cardiac arrest here as a team lead, working the scenario and all that, and if you would have took that first time that you worked that cardiac arrest as a paramedic, but have taken that whole situation out and you haven't worked a cardiac arrest until you actually got on the ambulance and worked your first cardiac arrest on a live patient, you ain't going to know what to do. We can talk about it all day long in a book, but you're not going to know what to do. It's just like firefighting or any other technical hands-on thing, is you're not going to know what to do until you get repetition. Okay? I've always said repetition equals remembrance. Repetition equals remembrance, whether it is neurological remembrance or it's muscle memory or what. But repetition and practice gets us to where we're at. Okay? So, critical patients may involve, or managing critical patients may involve being confronted with pre-morbid or peri-arrest conditions. What does pre-morbid mean?
Yeah.
Okay, in a sense, I guess you could use those words there, but for in this case, pre-morbid conditions are going to be conditions that that patient could have had that have contributed to their overall condition now that they've experienced something serious, right? You take a 50-year-old man who has a lifetime of smoking and coronary artery disease and all that, and you take a 22-year-old, put them both into cardiac arrest, the 22-year-old is most likely going to fare much better because the 22-year-old doesn't have near as many premorbid conditions as the 50-year-old man does. Does that make sense? And then peri-arrest are going to be those things during the time of the resuscitation. Now remember, when we talk about resuscitation, we're not just talking about cardiac arrest resuscitation. We're going to talk about resuscitation in the sense of a person is on the brink of death or their body is in a impairment that we're trying to resuscitate or pull back into some normal numbers. Remember, the body likes its numbers. Our goal is to try to get a critical patient back to as close to a homeostatic balance as possible, okay? With the understanding that we're not going to cure that situation. We're not going to completely reverse what's going on with them for that critical patient. But what we can do is manage them at least to the point to where they're stabilized, hopefully, not every patient, but hopefully to where we can get them to the hospital, okay? I saw this little diagram. You're not going to see this in your book. It was actually on an article that I read. But excellent decision making comes with experience. It's acquired through training, internships. It's everything that you're doing now. Okay? The thing that I do warn you about, I know that a lot of you guys are working on the ambulance and you're working in EMS already, and I completely respect that. But what I warn you is you don't want to take that for granted and think that what you're doing right now, driving the truck and assisting, is the exact same role as what you're going to do when you graduate from paramedic school. Okay? Because if that was the case, then we might as well just forget these 3 semesters and just put you on the back of the truck, right? And so don't overestimate your experience. Now, I'm not taking away from the fact that you are getting experience in the field. I'm not. But what I'm telling you is that it is a different role, okay? And so you need to try to take advantage of all of the situations that you're in the scenario labs. I know, yeah, they're big dolls. They're big dolls. We're sitting there playing with big dolls. We're having to use our imagination. But I would much rather you be sticking a big doll, be doing cardiac arrest, working, compressions, intubating, or whatever on a big doll to get you ready to do all that stuff to a person, right? But this little thing right here I thought was kind of funny, but I also, ever since I've been teaching, I've always said there's a difference in confidence and cockiness. What's the difference? Confidence and cockiness. Let me ask you something. If you've got a paramedic that's taking care of your family, your child or your mother or whoever, do you want them to be confident in their skills? 100%. There is absolutely nothing wrong with being confident in your skills. Knowing what you're doing. That's what we want for you guys. For your guys. That's what we want for y'all. Right? You may not, and I'm going to have this on a recording, but you may not pass registry the first time. That's a long time away. We're going to do everything we can to get you past registry the first time, but I don't care about a test as much as, are you going to be confident in your skills? Are you going to take the things that we taught you in the classroom, in the lab, and you learned from other medics out in the field? Are you going to take those things into your practice, and are you going to be confident in them? Because confidence is what we're looking for. Cockiness is what gets somebody hurt. Cockiness simply means that you're overestimating. You're compensating someone, right? When you're cocky, you're going to get somebody hurt. Because cockiness, it looks at the within and sees what can I do that's best for me. Whereas in confidence, that looks on the outside and says, I want to use my skills to do the best that I can for others, right? But the evolution of a competent EMS provider, this isn't even talking about in your internship. Because I promise, you're going to be a lot more comfortable in your internship, even though you're nervous your first day or whatever, you're going to be a lot more comfortable in your internship than you are that first shift as a paramedic when you've actually got your license. Because you're going to go from a whole new world. You're going to go from, I've got a safety net, I've got somebody to fall back on, to I'm the person calling these shots. I'm the person that is making these decisions, right? So you want to be confident in that, right? I'm not saying all this to scare you, and I'm not getting on a tangent. I promise we're going somewhere with this. But I should have printed off that thing and let y'all read it. But the first year, you got the terror. That's just that's where you're going to start getting a little more comfortable. But I don't know that being terrified is the right word, right? But maybe being a little uncomfortable probably isn't a bad thing, because that keeps you alert. That keeps you to where you're learning new things all the time. The problem is that as you get that increased comfort, you think that you've seen it all. You think that you've done it all. And now you're God's gift to EMS. I was going to be God's gift to EMS education when I started in 2012. 11 years later, I realized that I am in fact not God's gift to EMS education or EMS in general. But I'm just trying to do the best I can. Because that increased comfort comes cockiness. And this is where you really got to work on, okay, I know what I'm doing, and there's nothing that I can't handle, because there's going to be a reality check that comes one day. And that might be in the form of a really, really bad call. That might be in the form of just a patient that somehow affects you in some way. That may be in the form of an error that you make, or an error that somebody else makes, or something like that. But there's going to come a time where there's going to be something that you're experiencing that you haven't experienced before, and it's going to kind of make you realize, hey, I hadn't seen it all, and I can learn something new every single day. Because I know a lot of people that are still right here, and if you can't get out of this to the confidence, then It's basically like being stuck as a teenager your whole life. Like, you're not going to actually be able to thrive and grow, right? And that's one thing that I really hope for all of y'all, is that as you move forward, you continue to thrive and grow in EMS, in pre-hospital, or whatever field you take, all right? I got a little video here. If you've seen this video, please don't say anything, just watch it.
Of attention. Count how many times the players wearing white pass the basketball. How many passes did you count? The correct answer is 15.
We got
passes.
15.
But did you see the gorilla?
Did y'all see the monkey?
I saw the monkey, but I didn't even try and count.
Alright, I want you to be honest. Who did not see that monkey? I didn't either the first time I ever saw it. Why? Why? What's the lesson that can be learned here?
This video is from research by
Yeah.
Daniel Simons and
They passed the
Christopher
16
Brady and is
color.
copyrighted.
I don't think that was the point in the video.
And teaching on DVDs from BizCog Productions.
So the point in the video though is the fact that we got so focused on how many times they were passing the ball that we didn't maintain situational awareness. Does that make sense? Here, y'all just take one and pass it. That's those calendars that I remade. All right.
Is 247 the one where our exams are gonna be online?
Yes.
And this ones are in person?
All right. So, don't just get so focused on the task at hand that you forget that there's other things going on as well. And that was the whole point in that video, is that we get so focused on the task at hand that we miss the big monkey that walks by. There's a saying that I use in this class, and I guarantee you if you ask anybody that's had my class in the past 11 years, they will know exactly what I'm talking about. But if it walks like a duck and talks like a duck, it's probably a duck. Unless it's an elephant that has a duck bill strapped to its snout. And we are so focused on the duck bill that we miss the big old snoot that's coming off the elephant. All right. I know that's a bit of an exaggeration there, but what I'm saying is that yes, we should in most situations. If it walks like a duck and talks like a duck, it's probably a duck, right? But we've got to maintain situational awareness so that we don't miss that gorilla that walks by. Many adult patients have pre-existing conditions. So that's what we're talking about, the pre-morbid or the pre-existing conditions. What are some things that you think would affect patients that are pre-morbid conditions that could make them go from the sick to the critical patient category in certain situations?
Hypertension.
History of hypertension, uncontrolled hypertension especially. COPD, any type of like restricted airway disease. If you think about it, somebody that's starting to have issues breathing, if they've already got a disease that locks them up anyways, it's going to be even worse, right? Heart failure, renal failure. Renal failure is a big one. Renal failure is a disease process that you will see a lot. A lot with patients that have uncontrolled hypertension and uncontrolled diabetes. if you have a renal failure patient, you're doing a dialysis tote or something like that, look at their history. If you have their chart, look at their past history. And I guarantee you, to an extent, because there's always outside of that extent, but they're going to have hypertension and diabetes, right? Because they were comorbid factors that continue to work on the kidneys. But there's a lot of things that are comorbid factors, and so you've got to be where you're understanding that. Just because this patient is a trauma patient doesn't mean that the pre-existing conditions are not going to affect them. What if that patient is taking anticoagulants, right? What if that patient's on blood thinners and they have a bad wreck or they have a bad traumatic accident and they're bleeding, right? That's a premorbid issue, right? Because we're now having trouble with bleeding. So it could be drugs, it could be conditions, previous conditions. One of the things that we'll see when we talk about stroke is the thrombolytic checklist, and they talk about premorbid conditions there that we may not be able to give thrombolytics to. Okay? So this is just a little chart here that we're basically doing this stuff, and it's trying to get a broad. What you're doing on scene is trying to get a broad to a narrow. Basically saying that there's a lot of stuff that we could be experiencing right now, and we need to work through so that we can get it to a narrow. So the scene size, that's always going to be an ongoing process, right? We know that our patients are dynamic. Conduct a primary survey. Should you be able to do your primary survey pretty quick? Yes. What are the 3 things that we're looking for in your primary survey? No, we're looking at seat safety before that. What? Airway breathing and circulation. Then your secondary assessment. Remember, sometimes your vital signs, there might be some vital signs that we can't wait to get in our secondary assessment. Okay? If we think a patient's in shock, then we need to get their blood pressure. If we think a patient's experiencing respiratory failure, then we need to count respirations and we need to get SpO2. Okay? Consideration of the most serious conditions. This is where we're going to rule the serious conditions in or out. Alright? And my rule of this is we're always going to keep worst case condition in the back of our head. And we're always going to be looking for those things that lead to that while trying to rule out other serious conditions. Prepare a short list of causes of today's problem. Do you think you're going to go to every single patient you see and automatically know what's wrong with them? No. Can you always take what dispatch gives you and automatically know how you're going to treat that patient? No, you cannot. Guys, I know this is a bunch of words up here, and I know that we're past this. We're in paramedic school, but I'm telling you, you're not going to be able to diagnose every single patient as soon as you walk up. You're going to have to work through some stuff. You're going to have a list of things. You're going to have to think through those things. Now, I'm not saying we're going to sit there and write it all out and all that, but it's got to be a noggin thing. You've got to be able to think through. That's why we go over so many diseases. That's why we go over so many traumatic issues. That's why we go over cardiac arrest over and over. That's why we go over all these heart rhythms over and over. That's why we learn how to read 12 lead, because we're using all of those diagnostic tools so that we can get to right here. All right? Transport to the most appropriate ED and consult with medical control as needed. Provide reassessment and update priority. Narrow down the differential diagnosis to your field diagnosis. Do y'all understand the difference between a differential diagnosis and a field diagnosis? A differential is a list of things that we're working through that hopefully we can finally get down and point right at the field diagnosis. Now, will that field diagnosis possibly change? It may. It may. Could you be way out in left field and be treating the wrong thing? That's a fact of life. That's a fact of life. I mean, your 2 years of training, I'll give you a pass on that. over a doctor's 8 to 12 years of training to miss something. But there are going to be those patients that we do miss things at from time to time. But if we go through this process, then it'll make it a little bit easier. Okay. To consider differential diagnosis for an altered mental status, you can use the acronym MT-SHIP. MT-SHIP. So if y'all have done the prep work, you had to do it, but the M is medication overdose or non-compliance metabolic causes. T, tumors, trauma, toxins. S is seizures, stroke. H, there's a whole bunch of them. Hypoxia, hypothermia, hypoglycemia, hypertensive crisis, hypovolemia, hyperkalemia, hypokalemia. I, infection and uremia. P, psychiatric or behavioral disorders. Also for patients with chest pain, you gotta think about, there may be, and we talked about this in 241, there may be several causes of that chest pain that are not cardiac related. But the general rule is that all chest pain is going to be treated as cardiac until proven otherwise. But there are things. You could have GI system issues, heartburn, esophageal spasm, gallbladder, pancreatic issues, musculoskeletal issues, sore muscles, injured ribs, respiratory causes, PE, pleurisy, pneumothorax, panic attack, shingles, cancer in the chest. The list goes on and on. And I think one of the points here in just keeping that list going on and on is just to help you realize that there is a lot of things that could be going on with that patient. And so what if I get stuck? What if I just cannot figure out what the symptoms are and treat them? What if they got some kind of respiratory disease or something and I can't figure out what's going on? Do they got a SAT of 80? Then give them oxygen and treat them, get them to the hospital. Right? At the end of the day, that's what we've got to do. Okay? What do you think? What do you think the role of intuition is in EMS? What is intuition?
It's like that gut feeling you get about something.
It's that gut feeling, and it's usually comes along with something's just not right. I've seen this situation before. Something's just not right. Basically, it's your body playing off of possible experience that you've had before. So it's pattern recognition and matching based on previous experience. Intuition in the field, y'all remember this, intuition in the field can always be used to up triage a patient, but it should never be used to down triage a patient. Does that make sense? So I know that he's having chest pain. We've called 911. Okay, well, I can up triage and say, well, he's a young guy. He probably isn't experiencing chest pain, but I'm going to treat it as cardiac anyways, right? I'm going to do the 12 lead. I'm going to up triage just because chest pain is not. I've had patients in the past that have had chest pain and they had MI, right? So I can up triage. I can make him a little more critical than what he may be, so that I can get more attention to him. But I'm not going to say, oh well, he's just a young dude that he's fine. Ain't nothing going to be wrong with him. He ain't having a heart attack, something like that, right? Because didn't you have something? An issue? No, it was you.
Mm-hmm.
It was you that had the SVT and the ablation, right?
Mm-hmm.
So, see where that could get you in trouble? If he calls 911 with heart issues and he can't really get the information out to me that, oh, I've had heart issues in the past, I'm going to go to him and be like, dude, you're a firefighter. You're young. You're fit. There's nothing wrong with you. That could get me in trouble. I've known several Auburn Fire guys that have had some really weird. There's one dude that was 19 and had a stroke in the middle of the parking lot. That's one of my former students. What I'm saying is that, yes, 9 out of 10 patients that call with chest pain that are, how old are you? 21. There's probably not, they probably smoke some weed or something. But that one patient that has a history of cardiac issues, that maybe he went back into SVT or something like that, right? And so I want to make sure that what if I'm wrong when I up triage? Well, that's much better than being wrong and down triaging and taking a patient that you say is bullcrap and it ended up being something serious. Don't make decisions based on intuition that draws on incorrect experiences. Another issue that you can run into with intuition is experiences that you have went through before that now you are downplaying on that patient. Meaning, let's say that I've had a shoulder dislocation and it didn't hurt me too bad. I was cool. I was fine. I mean, I got up and oh man, it hurt. I went to, but then I've got another patient that I went to pick up myself, and they said, I'm having, or they got a shoulder dislocation, and they're like, it's 10 out of 10 pain. It's the worst thing ever. Oh my gosh, I'm about to die or whatever, right? I can't use my experience with my own personal experience with that shoulder dislocation to downgrade what they're saying to me, okay? Oh, I've had that before. You're fine. Well, they may not be, because we got different pain tolerances and things like that, right? So you want to be careful that you don't use past experiences to downgrade patients either. Also, when it says here, don't make decisions based on intuition that draws on incorrect experiences, you got to rely on your own experiences, not some made-up experience and not some experience that I told you about. Not something that I said, well, I took care of that patient one time. Like, intuition is a really hard thing to kind of work out in your gut when you first start in EMS. Okay? So, what about your partner? What if you've got that patient that they just don't look good, but they've just got a little bit of like chest discomfort, but they just don't look good. But they're really not showing any bad vital signs. They're alert and oriented and all that. And you're with your partner, and you're like, there's something wrong with him. I don't know what it is, but there's something wrong with him. How do you explain that to somebody? Especially if it's a situation where from all outside looking in, there's nothing wrong with that patient. But you had a patient like that before, where there's just something about that patient that don't look right, that you need to explain that to your partner. Well, good for you, there is a handy dandy little process. Carl White's process for communicating intuitive decisions. Here's what I think we're dealing with. Here's what I think we should do, and here's why. Because if you're coming at me saying something's completely different than what we think it is, I need to know what you're thinking. But your partner needs to respect you enough to where they'll work through it with you. Here's what we should keep our eyes on. Do you got any other concerns? And I skipped this right here, I didn't mean to, but intuition can keep you out of trouble by forewarning you, or it can get you in trouble by leading you to make treatment decisions based on inaccurate assumptions. Forget about that. Somebody messed that up. Alright. I'd say it's about right time. Let's take a break.
This is an extra.
You're so embarrassed.
Yeah, that's all I
Did you put any aloe or anything on that?
I got some of that hemp lotion.
This man's a man.
and stuff.
It's an iPhone.
Yeah, you won't be a man when you get skin cancer.
Alright, moving on. So, bias in decision making. This is actually kind of interesting here. there's a term here that your book doesn't use anymore, and they used to use it, but it was called heuristics. And heuristics are mental shortcuts that allow people to solve problems and make judgments quickly and efficiently. These rule of thumb strategies shorten decision-making time and allow people to function without constantly stopping to think about their next course of action. For example, examples that employ heuristics include using trial and error, rule of thumb, an educated guess, an intuitive judgment, a guesstimate, profiling, or just common sense. Basically, heuristics is if it walks like a duck and talks like a duck, it's a duck. That whole term right there just basically means, okay, I've seen this duck before, it's quacking, and it's swimming, and it's paddling, and all that. There's no other reason in this world for me to believe that this is an elephant with a duck bill strapped to his face, right? And for most of the time, that's okay in decision making. For most of your calls, the only thing that I warn you is to watch out for tunnel vision and maintain situational awareness. Okay? Because you can get into these situations where you are biased, you've already formed an opinion in your mind, and at that point, you're trying to find anything that supports what that decision is. Okay? So, confrontation bias is a tendency to gather and rely on information that confirms your views. It's actually confirmation bias. So, confirmation bias, a tendency to gather and rely on information that confirms your views and avoids or downplays information that does not confirm your pre-existing hypothesis. And then anchoring bias is allowing an initial reference point to distort your estimates. One of the biggest issues that we run into in the field with anchoring bias is going to be dispatch. Does that make sense? There's a lot of times that we may get anchored on what dispatch sent to us. And so when we go into that situation, we're already trying to find what we've already assumed in our mind. You see a lot of this kind of stuff in politics. Basically, it's saying that I'm only going to associate myself with things that support my views. I'm only going to find evidence that this patient is, in cardiac arrest. I've already made up my mind this patient's in cardiac arrest. I'm only looking for evidence that confirms what I've made my mind up. Does that make sense? But that's not how the scientific process works. Why am I bringing that term in here, scientific process? Because that's what basically a differential is going through a process, a scientific process, right? So, all of that, a bunch of words to say, be mindful about making a misjudgment based on overconfidence. Search for information refuting differential diagnosis and look at all angles of the problem. Don't just get anchored onto what you think it is. Leave room in your mind to maybe explore other options, okay? There's nothing wrong with relying on your experience. There's nothing wrong with relying on the rule of thumb generally, but always leave an open mind, okay? When treating a patient with classic presentations of a specific condition, don't assume the patient has the condition before obtaining information. Don't prematurely jump to conclusions when assessing a critical patient. We also use this in psychiatric and behavioral emergencies too. I've got a known patient that has schizophrenia, and they're calling today because they're having chest pain. Well, I can't just assume that because this patient's having schizophrenia or has a history of schizophrenia that that's what is going on today. Like, I have to treat the chest pain. Does that make sense? Alright, so if you're following along with me, I'm going to skip a snapshot of critical decision making. I'm going to skip that. I'm going to go to the thinking under pressure, fight or flight. Most of the time, you wake up from a dead sleep in the middle of the night. Alarms go off. Fight or flight. Right? You are going down the road trying to get some lunch, and alarm goes off. Wreck on 280, fight or flight, right? That's what we live off of. That's what you live off of at work for 24 hours or for 8 hours or for whatever it is. When I'm at the ER, yeah, I may have some critical patients or whatever, but for the most day I have forewarning, right? I have like folks bringing patients in and they may be critical, but I don't have to go through that whole shock stage of getting the tones and all of that, right? And so you've got to overcome that. And a lot of y'all may be learning how to do that now, but I remember as a young medic and really getting into it, I used to love the tones because I love that feeling of that rush and all that, you know. But I could also see myself not really focusing on the task at hand. Your fight or flight, you got enhanced visual and auditory acuity, improved reflexes, and enhanced strength because your fight or flight is a protective mechanism for you, right? All of these are things that can save your life. I've got somebody after me, I'm about to die. Enhanced visual and auditory acuity, hopefully I can see them better and hear them better so I can get away from them. It's primitive. That's the word I was looking for earlier. It's primitive. Like it's one of our fight or flight is one of the systems in our body that works exactly the same as it did however long ago. Improved reflexes, enhanced strength. I once knew a mom, now she was a big mama, but she wasn't strong enough to lift up a race car, and I saw it with my own eyes out at the dirt track. Her son had a race car fall on him, and she lifted that mug off of him so that people could pull it. Like, fight or flight. I'm telling you, it'll make you do some crazy things. But your critical thinking skills, this is where you've got to work really hard to really start thinking through this. And even maybe to the point to where you've trained your body to where it doesn't even go into this. Right? I'm not saying there's anything wrong with that fight or flight mechanism, but professionals learn how to take these stressors and learn how to turn them around to benefit them so that they can work stronger in the situations. Because if I'm just thinking under pressure and I am, you ever been on a scene where you could just tell, you probably not thought of it until now, but you just tell that person's fight or flight was working in overtime? Meaning they're bringing more chaos to the scene than what they really need to be doing, right? You don't want to be that patient. You want to be able to work through those situations, right? Mental conditioning that results in instinctive performance and automatic responses for technical procedures is the key to effective performance under pressure. That's a lot of words for this. You play like you practice. Who's athlete? Who's athlete in here? Did you have to do repetitions? My kid's on the All-Stars right now for Beauregard, and he had batting practice last night. And I bet you he's won that bat 150 times in 2 hours. Why? Because we're trying to condition ourselves. Your brain is no different. You've got to mentally condition yourself. That's why we do cardiac arrest. We're going to do more cardiac arrest. I've always said I'd rather work at cardiac arrest than any other thing. Not for that patient because it stinks for them, they're dead. But I don't have to really think in those situations. I just react, right? And we want to get ourselves to the point to where we're at that fine line where we can be reactive when needed to, but we can control that reaction as well. Does that make sense? Like, I need to be able to just react in some situations, but in other situations, I need to be able to go at a more of a controlled rate or a controlled reaction, I guess. So when thinking under pressure, stop and think, scan the situation, decide and act. Maintain clear and concise control. Regularly and continually reevaluate your patient. All of these things are very important, but this, to me, well, actually, this, you've got to make a decision. Somebody has to make a decision. Y'all know what I'm talking about. Like, you trying to figure out where you want to go eat.
Shit's rough.
Just make a decision, right? Somebody's got to make a decision. We can't be arguing over whether we want to go to Taco Bell or Burger King or Mi Ranchito or whatever on the scene. Like, somebody has to make a decision. And maintain clear and concise control. Make sure that your scene is going in a manner that is not going to be where it gets out of hand. I mean, that's the fact of the matter. Is that's your scene, all right? Hopefully, you've got other folks that are going to help you maintain control of the scene, but ultimately, you've got to make sure that the patient is getting what they need, and we're staying in control. Now, does that mean that I'm barking orders and all that at everybody? No. What that means is that I am making sure the patient is getting what they need by staying in control of the patient. Okay? We're going to get to something here in a minute. All right. So, read the patient, read the scene, react, reevaluate, revise your management plan, review your performance at run critique. I'm not going to get into all that right now, but QC is very important. Y'all ever been to a run review? If you get the opportunity at an agency or something, and I'm sure that once the fire department starts doing ALS, they'll probably, especially early on, go to run critiques, go to run reviews, because you can learn a lot looking. What's the saying? Hindsight's 20/20. What?
What are they?
It's where the medical or your medical control reviews runs that you've had maybe from the previous month or something like that, and you meet up and you discuss it and all that. A lot of people think that they are punitive or they're there to get you in trouble, and they shouldn't be. They shouldn't be. You know, they shouldn't call you out for doing something wrong. They should say, maybe we should adjust this. Because hopefully, if you did something wrong to the point to where it affected patient safety, they didn't wait for a run review to talk to you about it. Right? So, I know that that was kind of probably not what you were expecting really medical to start out with, but I want you to understand that you've got to be in that process where you can critically think and make clinical decisions on your feet. That's part of this job. Okay? Now, the last part of this is really not part of the medical classes objectives or whatever, but there's nowhere else that we really go over shop because you don't have a patho class anymore. And so I want to make sure that we spend a little bit of time going over shop, because do you remember what I told you in cardiology? It all goes back to what? Cardiac output, right? Cardiac output. It all goes back to cardiac output because cardiac output is going to lead to perfusion. It all goes back to cardiac output. It all goes back to perfusion. So, shock, state of collapse and failure of the cardiovascular system leads to insufficient perfusion of organs, tissues. Shock is a normal compensatory mechanism. What we have to do is try to figure out, are they in a compensatory shock or are they starting to decline? Untreated shock will lead to death. Okay? So what are some things that the body requires in order to have perfusion?
Oxygen.
All right, so you got to have volume, you got to have oxygen. Not just volume though. Volume of what? Blood. You got to have red blood cells. You got to have plasma with red blood cells in it. You got to have oxygen. Those are very important. Mechanically, you got to have a pump that's working, right? You've got to have a container that is closed. What do I mean by a container?
No vessels.
Your vessels, right? Your vessels. It's a closed container. Your cardiovascular system, you got to have gas exchange both at the alveolar level and at the cellular level. You've got to have an adequate pH, because pH, you should have learned this in airway, but pH affects either the delivery of oxygen or the ability to receive oxygen. So the 3 P's of perfusion. Crap. Pump, pipes, and plasma. Your heart, your pipes, and the volume that is taking everything around. The heart's contractility allows it to increase or decrease the volume of blood pump, which is going to be cardiac output. We know cardiac output is stroke volume times heart rate. There's a couple of other things that we're going to talk about too, and that's going to be mean arterial pressure, cerebral perfusion pressure. In order for the heart to work, you've got to have adequate contractility, which is going to be the strength of it to squeeze. The heart also must receive adequate blood. I told you to think, last semester I told you to think about the blood that is being returned back to the heart as, what's that term? It starts with a P? What? Preload. Preload. Volume returning back to the heart. The resistance to flow, or the resistance that the pump has to overcome, is called afterload. Within our body itself, our blood pressure is usually auto-regulated. Why are we talking about all of this with shock? Because there's several different mechanisms that can affect the way that our body regulates blood pressure. And really, in medical emergencies, in medical issues. You could have kidney issues, you could have neuro issues, you could have cardiovascular issues. All of those could affect blood pressure in one way or another. But mechanically, blood pressure is auto-regulated depending on cardiac output, systemic vascular resistance, and blood volume. And so what all of these combined are going to send signals to baroreceptors, chemoreceptors, and they're going to tell the vessels to either expand or dilate, right? If pressure gets to be too high, they're going to, expand and dilate is the same thing. To dilate, if pressure gets too high, they're going to dilate. If pressure gets too low, what are they going to do? They're going to constrict to try to fill the container with what little volume they have. So, do you remember mean arterial pressure? Mean arterial pressure is probably, in my opinion, more important when taking care of a critical patient than a systolic blood pressure. Because mean arterial pressure is going to be the pressure that is required to sustain organ perfusion to the brain. Okay? If we lose the ability to perfuse the brain, then we're not going to have a whole lot going on, all right? But let me show you this right here. Do you remember talking about therapeutic hypotension? Therapeutic hypotension? That was where if a patient's in shock, we try to get their blood pressure to what? Systolic? 90, unless they got a head injury, and we'll go a little bit higher, right? Well, here's the thing. MAP, if we look at our MAP, and I hope that y'all know what I'm talking about, MAP, is on your blood pressure. Whenever you take your blood pressure, it's going to give you 120/80 and then the mean arterial pressure. Alright? So, basically what you would do, so let's look at 120/80 to get our so if I went 120 So I got about 93, and so blood pressure at 120/80, which is what we would call normal blood pressure, our MAP is going to be around 93. What does your MAP need to be? What's the lowest your MAP can be in order to perfuse the brain?
65.
65. So basically what I'm saying here is that if you can maintain a MAP of 60 to 65, you don't have to load them down with fluids to try to get their systolic blood pressure up and all of that. Alright? So the body's perfused via the CV system controlled by the autonomic nervous system. We know that. We talked last semester of how the autonomic nervous system works with the cardiovascular system, the sympathetic and the parasympathetic nervous system. We know that they both play a huge role. Okay? So this is kind of a review right here. Alveoli receive oxygen-rich air from breath. Diffusion is going to occur, and so hopefully we will have diffusion at the alveolar level, and we will eventually have that movement at the cellular level as well. Once we have perfusion occur at the cell, then we have waste products, and carbon dioxide is dissolved in plasma and attaches to the blood's hemoglobin, where it also combines with water to create carbonic acid and breaks down at the lungs, and carbon dioxide is exhaled. So basically, the carbonic acid, the carboxyhemoglobin, they basically pick up, the cells take the oxygen to the blood cells take the oxygen to the cells, they pick up the carbon dioxide and they transport it in the blood in the form of carbonic acid, and once it hits air, it has a reaction that turns it into CO2. Okay? Alright, let's talk about shock. This is really interesting. Shock. What are some things that shock? I know at this point we've learned that you've got distributive shock, you've got hemorrhagic or hypovolemic shock, you've got neurogenic shock, which is a type of, you've got all of your different shocks, but at the very core of it, we're going to have hypoperfusion that results from some mechanism that either causes inadequate cardiac output, a decreased systemic vascular resistance, or just profound hypotension, or an inability of the RBCs to deliver oxygen. At this point, once we start getting to the hypoperfused state, the body starts shunning, right? The body starts deciding, and there is a pecking order in which the body shunts from different organs. But it shunts from the non-essential organs to the more essential organs. When you have disturbances in normal perfusion, you have issues where you start having buildup of waste products. Remember what the process of metabolism without oxygen is? Anaerobic metabolism, right? And the byproduct of that is a lot of acid and heat, but very little energy, right? And so that's what we're trying to prevent. Also, inadequate perfusion will cause damage to the cell walls, which will, what would damage to the cell walls actually cause as far as like osmosis is concerned and fluids? Yeah, it could cause the cell walls to become leaky. Okay? Death is going to ultimately occur. The body's going to try to compensate to keep that blood or that death from occurring, but the body can only perfuse for so long. So the perfusion triangle, Chris is going to talk about this some more in trauma, but I know that you're only going to retain a little bit about what we've talked about all day today, but if you do retain anything, retain this. Know what the perfusion triangle is. Okay? The perfusion triangle consists of your pump, your container, and your content. Or your heart, your blood vessels, and your blood. And what we've got to do, at least academically, when we're trying to figure out what type of shock it is, we've got to figure out what mechanism is causing the hypoperfusion, or what mechanism is causing the hypotension, which is leading to the hypoperfusion. So damage to the heart by disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. Do you think that premorbid factors could affect the patient's compensatory mechanism when it comes to maybe cardiogenic shock? Do you think the body would be able to sustain if that patient has a history of CAD and MIs in the past and all that? Probably not as well as a more healthy heart, right? What about blood vessels? If all the blood vessels dilate at once, the normal amount of blood volume is not enough to fill the system and provide adequate perfusion to the body. And then blood, if enough blood or plasma is lost, the volume of blood or fluid in the container is not enough to support the perfusion needs of the body. Here is one way that I try to get you to think about the container and the fluids. So when you have a dilatory issue, your vessels are dilating, right? Your pressure's going down, okay? But it's not a volume issue. All right, so you think about this cup. If it's full, if this cup is full, and it has this volume in it, it's full. So pressure. Let's just think in terms of imaginary. Pressure is going to be high because it's full, right? Well, if my vessels dilate, and now this trash can has become my container instead of the cup. The volume that was in the cup is still the same as it is in the trash can. It doesn't fill it, right? So this is a dilatory issue. This is not a volume issue. Okay? So what I'm saying is that if the volume stays the same, but the vessels get wider and they dilate, your pressure is going to go down. Okay? Could we give more volume to try to help with that? We could. It depends on what type of shock it is as well, because we may need to put some pressors on. We may need to give a pressor to cause the container to get smaller. Okay? So we got to look in and see, is it a pump function, is it a volume function, or is it a container function or issue? I don't think I touched the trash can with that, but just in case. All right. So other issues that happen in shock is the fact that the bleeding mechanisms or the clotting mechanisms get affected as well. Obviously, we know that blood clots control blood loss. Retention of blood because of blockage in circulation could cause more blood clots. Damage to the vessel wall could also affect the blood's ability to clot. Injury causes platelets to aggregate at the injury site. I cut myself. The first line of defense is what? Platelets all coming and clumping together, right? And at that point, the red blood cells will clump together, and then fibrinogen, or the fibrin, the fiber that forms your scab. My wife hates that word, the scab. They come in, and the clots are prone to rupture because blood is always moving due to blood pressure. That's one of the reasons why we got to try to keep that blood pressure on the lower end in somebody that is bleeding, right? If we've got a clot somewhere, we don't want to flush it out, okay? But when the pressure starts failing, you got neural and hormonal mechanisms that are triggered. What's going to be the first thing that's triggered when they start noticing that your blood pressure is dropping? Your sympathetic nervous system. Because the sympathetic nervous system is going to release those catecholamines that act on your alpha and your beta 1 and your beta 2 adrenergic receptors, right? And remember, those are the ones that control systemic vasodilation or constriction. your parasympathetic nervous system, which will control involuntary functions, and the norepi and epi, that's what I was just talking about. And then the body fluids. The issue with the body fluids is that the body may actually have to shift. It may have to do its own shift of fluids out of cells or into cells or whatever. How do you think that happens when they shunt? There's actually a mechanism that tells the fluid to move out, and it clamps down. All right? The body responds to any event that leads to decreased perfusion in order to preserve vital organs. Baroreceptors. What do you think baroreceptors do? Baro.
Pressure.
Yep. You ever heard of a barometer? A meteorologist, they say, let's check the barometer. Or chemoreceptors, what do you think they're measuring? What? Yeah! Shifts in carbon dioxide in the arterial blood. Why do you think it's important to measure chemoreceptors? Or why do you think it's important to have the chemoreceptors to measure the CO2? What's the CO2 maintained within the body? Acid base, pH. And you probably don't remember, but maybe you do. Remember talking about a shift to the left or a shift to the right on the oxyhemoglobin dissociation curve? When your pH gets all jacked up, you have issues with perfusion, which can lead back to this very thing we're talking about. The baroreceptors, they're going to decrease or sense decreased blood flow in the carotid sinuses and the aortic notch. And when they start noticing that the pressure is getting lower, they're going to send signals to the brain for the brain to send signals to the vessels to start constricting. Okay? So when we start seeing decreased perfusion, stimulation occurs between 60 to 80 millimeters of mercury, and this is where the sympathetic nervous system is going to release catecholamines, and then also the renin-angiotensin-aldosterone system. Y'all ever heard of that before? You have. You just don't remember. The renin-angiotensin-aldosterone system in the kidneys. So this is actually a big part of blood pressure control. Renin converts to angiotensin 1, angiotensin 1 converts to angiotensin 2, angiotensin 2 will then convert into aldosterone. Angiotensin is actually a chemical that the body releases that is very vasoactive, very vasoconstrictive. Have y'all ever heard of an ACE inhibitor? That's where an ACE inhibitor works. Angiotensin converting enzyme inhibitor. Angiotensin. So it works to keep the angiotensin 1 from converting to angiotensin 2. Therefore, it's going to not cause as much vasoconstriction. So why do you think this is released? This is activated. It's activated to tell all the cells to clamp down. Okay? What about antidiuretic hormone? Why would antidiuretic hormone, ADH, be released in shock? Okay, it does have a little something to do with fluids. What is a diuretic? Come on, guys, use common sense here. What is a diuretic? It makes you pee. So what would an antidiuretic do? It keeps you from peeing. Why would we want that to be released in shock? We don't want to lose any more fluid. We don't want to lose any more electrolytes. Remember, sodium, potassium, those are lost in our pee. Glucose is lost in our pee. And then the fluid base, the plasma base, is lost in our pee. So antidiuretic hormone is released to keep us from peeing a lot too. We're essentially starting to get very, very dehydrated because we're sending all of our fluid to the core. Okay? The overall response is to increase preload, stroke volume, and pulse rate. So when we see decreased perfusion, all right, I want y'all to think about this for just a minute. Use your thinking caps. The body is trying to compensate, so it's trying to maintain perfusion, and the ways that it's doing it is to increase preload. Now, is the body creating any more fluid? It's not, but how is it trying to increase preload to the heart? By vasoconstricting, getting blood back, we're increasing pressure, so we're hopefully sending more blood back to the heart. We're going to try to increase stroke volume. Well, how is stroke volume increased? Well, not quite. I mean, it would be with heart rate, but think about it with preload. If preload's increased and the heart's pumping, then stroke volume is going to be increased, right? Does that make sense? And then heart rate. So one of the first things that the body does, especially in a child's body, in a response to a stressor, is going to be to increase heart rate. Okay, but during this compensatory or compensatory stage, if our body is increasing preload and stroke volume, we may see blood pressure as fine, as normal, because it's compensatory. But then once myocardial oxygen demand increases and we're shunting more oxygen to the heart instead of the body, then you're going to start seeing a lack of tissue perfusion in the body. The compensatory mechanism allows the body to compensate for a volume loss of up to 25%. So you can lose up to 25% of your circulating volume, and the compensatory mechanism is still going to work in your body. All right, so how much is that? What's the average person have in liters of blood? 5 to 6, right? So you can lose a quarter of that. So what's a quarter of 6?
2.
All right. No, that's a third of 6. Yeah. The bad thing is I have more than one person answer that really quickly. Okay, anyways, perfusion to the brain, coronary arteries decrease, and then the shifts, the cell switch to anaerobic metabolism like we talked about. What are signs of hypoperfusion? Dusky skin color. Oliguria. What is oliguria? Has something to do with pee. It's really just not pee. Oliguria. Impaired mentation. So you're going to have to be able to identify shock early. Okay? Talked about the alpha-1 effects of norepi and epi vasoconstriction. All right, so do you remember this term, the golden hour? The golden hour. So basically the golden hour essentially says you've got an hour. Now this has been disproved to the fact of you do need to try to get them to the hospital as quick as possible, but they're just because if they hit that 1 hour doesn't mean they're going to die immediately. Okay? But to maintain circulation to the brain, the body will shunt blood away from the following tissues in this order. The placenta is first. So if she's pregnant, we're going to start shunting blood away from the parasite. Just kidding, I shouldn't have said that. We're going to start shunting blood away from the baby. Then skin. That's why skin, the dusky color, the pale, that's why your skin is one of the first signs. Then your muscles. Start getting muscle cramps. The gut, kidneys, liver, heart, then lungs. Skin and muscles can survive with minimal blood flow for a longer period than your major organs. Alright? Decreased perfusion leads to cellular ischemia. We know that. Long term, it's going to lead to systemic acidosis. And it's going to deplete all of our energy reserves, which includes our glucose and our oxygen. Ischemia stimulates increased carbon dioxide by the tissues, and now we're going to start seeing higher acid levels in the blood. Intracellular enzymes that usually help digest and neutralize bacteria are now bound in an impermeable membrane, meaning that we're not going to be able to get rid of bacteria. We're not going to be able to have a inflammatory response. Once we get to this point, we're going to start seeing cellular flooding, which leads to irreversible shock. When we get to cellular flooding, you've got accumulating acids and waste products that are just dumped into the body. And the way that that happens is you start having a buildup of lactic acid, carbon dioxide, and it goes down to the microcirculation, your capillaries, your arterioles, and it forms clots. You've got a couple of sphincters that keep blood from flowing, and then they start failing. We'll get there in just a minute. White blood cells and blood clotting systems are impaired. Decreased resistance to infection, and then you may also see disseminated intravascular coagulation. Y'all ever heard of DIC? You have, but you probably don't remember if you're saying no. DIC is a serious order where proteins that control clotting become active under abnormal circumstances. DIC is probably not something we're going to see a lot in the field, but DIC, I was just mentioning about DIC actually causes clotting to occur in the very small microcirculation. Oh, I guess I have a picture of that. But DIC causes all these clots, and then those clots actually will cause people to not be able to perfuse, and on the outer parts of the body, they'll be bleeding. So if you ever see a patient in the hospital that they say they have DIC, they're going to be outwardly bleeding, but inwardly they're going to have a lot of clots and stuff. It's a really weird mechanism that the body goes through. All right, so what happens? What are we concerned about with shock? Just what are we concerned about as far as organ failure and all that? So MODS, M-O-D-S. Have y'all ever heard of ARDS, adult respiratory dysfunction? ARDS is part of MODS, but it's the lungs. All right? So it's a progressive condition characterized by failure of two or more organs that were initially unharmed. So these are going to be secondary. So initially, something happened, and because of the hypoperfusion state, other organs are going to start to be affected. They're secondary. Each tissue has its own warm ischemic time. Warm ischemic time is going to be the time that it can essentially be shunted blood. Okay? Patients have a mortality rate of 23% to 100%. I like this because that's basically saying 0 to 100%. You're either going to die or you don't from it. MODS actually has a really bad or a very poor prognosis. Somebody gets into shock and they go into MODS, and if you think about it, anytime you hear the term multiple organ dysfunction, it's probably not going to be a good thing. Septic shock is one of the main causes, and then also fluid shock from burns. Okay? When the injury or infection triggers a massive systemic response, you have all these inflammatory chemicals that are released, and they activate what you see here, the complement system, the coagulation system, and the kallikrein-kinin system. I'm not asking you to really know all that to that point. Overactivity results in maldistribution of systemic and organ blood flow. The body accelerates tissue metabolism, and progression causes organs to malfunction. All right? And then the specific organs that we're looking at: heart, lungs, central nervous system, kidneys, liver, and GI tract. Like I said, ARDS is going to be non-cardiogenic pulmonary edema that is part of the MODS here. What causes shock? Whatever causes insufficient perfusion to the organs and tissues. In emergency medical situations, have a high index of suspicion. What does that mean?
Always be looking for shock.
Yeah, always be looking for shock, and always be thinking, like we talked about earlier, always be thinking in your differential. Like, if it's something that we see that the patient is just not doing well, we got to be thinking, what could it be? What could it be? Right? Now, I'm not saying that you need to hold up your care trying to come to a diagnosis, because we can always treat low blood pressure. We can always treat these signs and symptoms. But expect shock to accompany especially massive external or internal bleeding, multiple trauma, spinal injury, infection, massive myocardial infarction, and anaphylaxis. 3 basic causes of shock. It's going to be pump failure. It's an issue with the pump itself. It's going to be low fluid volume, so a hypovolemic issue, or poor vessel function, which could be because of drugs, could be an infection, it could be a neuro issue, something like that. Older adults often have decreased cardiac output and cardiac reserves, as well as atherosclerosis, affected vasoconstriction. So we're going to have some premorbid or comorbid factors that will affect their outcomes. Certain patients are more at risk, trauma or bleeding, MI, septic shock. Now, you don't see a whole lot of septic shock in the field. Usually, before they get to that point, they usually go get checked out, but it can happen really easy. Like, folks can get septic really quickly. All right. I'm supposed to do this. I have 9% left on my iPad. Did I hit resume on that thing?
Yes.
So shock occurs in 2 phases. Y'all know this: compensated and decompensated. Y'all talked about shock pretty good in advanced EMT. You should have it at least. There's 4 grades of hemorrhage, or 4 classes of shock in your prep work. I've got you to look at those. Class 1 and 2, that's going to be up to 25%. It's compensated shock of blood loss. Class 3 and 4 would be decompensated. There is a difference in decompensated and irreversible. But decompensated shock is going to lead to irreversible very quickly. Recognize signs and symptoms early on. That's going to be one of your big roles here, is to have a high index of suspicion for shock and to try to recognize stuff before we do a great job of teaching late signs of shock, because one of the main things you learned in EMT whenever you learned about shock was look for low blood pressure and a high heart rate, right? And poor skin perfusion, pale, cool, clammy skin, weak, 30 pulse. A lot of that's late signs. Hypoperfusion or hypotension is a late sign because the body is compensating to try to keep normal tension. Okay? So your compensated shock is your earliest stage. This is where we're going to still see normal vital signs. Decompensated is when you get past about 30%, 25 to 30%, you start seeing the compensatory mechanisms fail. The problem with decompensated shock, other than it being decompensated shock, is that the compensatory mechanisms are failing, and we don't really have a way to get them to start working again. Cardiac output falls dramatically. Cells within non-perfused tissue becomes hypoxic, leading to anaerobic metabolism. Now, sometimes treatment will result in recovery, but if you've got somebody that's hemorrhagic and we just load them down with fluids and they're constantly bleeding out without giving them like packed reds or something, you're not going to see a real high recovery rate. Once blood pressure drop is detected, the shock is well developed. All right. Don't be looking for hypotension and shock, because once you get to hypotension and shock, they've already been in shock for a while, right? We're trying to detect early signs. And then when you get to irreversible or terminal shock, the only real way I have seen folks live longer, not like die immediately, but I've not seen too many people like really do well once they hit irreversible, but that was when they were in the hospital, had, you know, we intubated immediately, they went into ARDS and went into MODS, and but once they get to irreversible, they've got renal damage, they've got tissue, end organ tissue perfusion damage. It's not good. Okay, you don't usually see that a lot though in the field. Not to the point to where you would treat it, because I'm not saying you wouldn't see it, but it'd be like in a multi-system trauma patient that is hemorrhagic and they're about to go into cardiac arrest, and you probably wouldn't load them up and take them to the hospital. Alright. So be sure that you're looking at your scene size up, your primary survey. So this is going to be important. Is that patient sick or not sick? Like, that's a rhetorical question. I'm not asking you, but I'm saying that's something you got to ask yourself. Are we sick or not sick? That's how the first steps in determining critical patients. Sick or not sick. Now, just because we say not sick doesn't necessarily mean that they don't have something going on with them. It just means that they're not a immediate, right? Some do not pass the look test and will need to be fast-tracked based on mechanism of injury or nature of illness. Airway and breathing. If you suspect cardiac arrest, obviously we're going to do CAB. Now, if you suspect bleeding, this is a little different. Chris will talk about this in trauma, but we got to kind of handle the bleeding. It's not going to do us a whole lot of good to do airway if they're bleeding out and we're not trying to stop that massive bleeding. Does that make sense? So we want to try to tourniquet or try to whatever we need to do to stop the bleeding. Manage immediate threats. If difficulty breathing, examine the chest. Especially in situations where it's going to be like a multi-system trauma. Your assessment, your ABC, your primary assessment is not done until you examine the chest in multi-system. Remember, you got to expose in trauma. Because you could have a patient that you missed that flail segment, or hey, be sure you look in the back too, because you could have a patient that you had an entrance wound for a gunshot and an exit wound, but you only managed the entrance wound. We still got a hole in the chest cavity, right? And we're still going to have difficulty breathing. Determine if your pulse is adequate. Provide immediate transport if really we're showing any signs of shock. All patients got to be prioritized. We got to figure out where we're going to take the patient. If it's a shock that's not from trauma, you might do okay going to a medical, but you don't have to go to a level 1 or level 2 trauma center. But traumatic injury definitely needs to go to high level trauma. There are portable lactate monitors that you can actually test lactic acid to see where they're, see if they're acidotic or whatever. You're not going to really see this on just a normal ground unit, I wouldn't think. And remember, the patients are always going to be dynamic, so we've got to make sure that we are paying attention and watching vital signs. Healthy, fit young adults are equipped to combat life-threatening blood loss. So remember, that's what I was talking about as far as like premorbid and comorbid factors. Healthy weight along with a diet of low salt, low fat, and low cholesterol prepare the body to handle the effects of epi, nor-epi released during shock. Usually it's those people that aren't going to be going into cardiac arrest or experiencing shock unless it's a trauma. All right. So when you're treating, airway and ventilatory support take priority when treating a patient with shock. Make sure that you control external hemorrhage. IV therapy can be helpful in supplementing initial therapies. If it's a hemorrhagic, we want to consider therapeutic hypotension or permissive hypotension. Maintain perfusion without increasing internal or uncontrollable external hemorrhage. Want to consider getting a large bore IV, volume expanders. We're not really trying to get a blood pressure of 120/80 when we're treating somebody in shock. Okay. If signs of tension, pneumo, perform the needle chest decompression. Have y'all learned how to do that yet? So we'll get that in lab definitely. With suspected cardiac tamponade, recognize the need for pericardiocentesis. What is Beck's triad? Remember Beck's triad with cardiac tamponade?
Muffled heart sounds, increased heart rate, and decreased.
So muffled heart sounds, decreased heart rate, or I'm sorry, muffled heart sounds, JVD, and hypotension. That's Beck's triad. All right. Why are you going to have hypotension in cardiac tamponade? Because you can't squeeze, right? There's blood surrounding the heart. Muffled heart sounds because there's fluid surrounding the heart and you're listening through fluid. JVD because you don't have output, so it's going to start backing up into the systemic circulatory system. Non-pharmacological therapy, positioning, hypothermia. Remember, we've got to keep the shock patient warm. All right, remember this. You got to keep the shock patient warm. I've heard it taught that if you're comfortable in the back of your ambulance, if you're not too hot in the back of the ambulance, you don't have it warm enough. Because that shock patient needs to be warm. They've lost a lot of their therapeutic or their mechanisms to control their temperature. IV therapy. We are going to be careful with fluids. All patients in hypovolemic shock need some type of IV replacement. If it's a hypovolemic and not a hemorrhagic, then fluids are excellent. You could even do lactated ringers or sodium normal saline or something like that. If it is a hemorrhagic issue, though, we're worried about it. We don't want to give too much fluid. Okay? Now, I mentioned volume expanders earlier. Volume expanders are going to be like plasma substitutes or just something to expand volume, but it's not going to have blood or oxygen carrying capacity. Okay? So hypovolemic shock should be treated with volume expanders to replace what was lost. You could consider some inotropic drugs or some pressors. Variety of solutions have properties similar to those of plasma, and we'll talk about some in just a moment. Plasma substitutes, you may see dextran, which is a high molecular weight glucose polymer. It stays in the vascular space due to its large size. It is a it has solute in it, right? Remember, it can't go across the semi-permeable membrane, and so it tends to coat red blood cells and may cause clotting problems in large quantities, and may also interfere with cross-matching of blood. Plasma protein fraction is something else. It contains a protein called albumin. and also serum globulin. Reported to produce hypotensive reactions in some patients, and then polygene head-of-starch. So again, all of these are going to be different types of solutions that resemble osmotic and electrolyte composition of the plasma. As paramedics, do we need to know this? Yeah, probably so. We may actually live in a world one day where we don't just automatically give just normal saline to every single person when we know it's not helping. Okay? Your crystalloids, the issue with crystalloids is that they don't carry any oxygen carrying capacity. Your common crystalloids are normal salines and lactated ringers. Lactated ringers actually has lactate, potassium, and calcium in it as well. So it's you don't see it used too often in the field. They don't carry oxygen, and they actually thin out the blood. So you're actually just creating just very thin blood that could blow out clots and things like that. All right. So let's talk about specific types of shock. So 3 classifications of shock. So you've got cardiogenic, distributive, and hypovolemic. Now that's not all the types of shocks, but that's just the classes of shocks. Does that make sense? Because you could get an anaphylactic, a septic, or a neurologic that are distributive shocks. Hemorrhagic or hypovolemic goes under hypovolemic. Cardiogenic, acute heart failure. And then even obstructive shock is actually another one that you could think of too. Obstructive shock is you're going to have pulmonary embolism or tension pneumo under that. Okay. Non-hemorrhagic causes of hypovolemic shock are grouped by how they reduce perfusion. One of the biggest ways that hypovolemic shock occurs is through just nausea, vomiting, loss of fluids through sweat, dehydration, things like that. All right. So it's always going to be managed airway on any shock. Supplemental oxygen if they need it. This is the time where it's okay to give oxygen. Cardiogenic shock. At the very core of cardiogenic shock, the very definition of cardiogenic shock is going to be what?
Pump failure. Pump
failure. That's right. And basically, the pump is no longer able to pump the fluid that's coming to it. Okay? And so, a lot of times it's accompanied by myocardial infarction, some type of heart failure. You're going to see poor contractility, decreasing cardiac output, and impaired ventricular filling. Cardiogenic shock, you're going to see hypotension, probably signs of MI. Always consider a patient that's been in cardiac arrest and you get return of spontaneous circulation. Always consider that patient in cardiogenic shock. Why?
Their heart has been dead.
Yeah, their heart was just dead. So they're gonna, that would probably shock anyone, wouldn't it? Alright. Some EMS systems use dopamine at low doses if the patient has a MAP of less than 60. Got to be careful with cardiogenic shock with fluids because fluid overload, exactly. It seems kind of silly if you've got a pump that ain't working just to put more fluid on it, right? All right. Obstructive shock, I talked about this just briefly. Causes are not directly associated with loss of fluid, pump failure, or vessel dilation. It occurs when blood flow in the heart or great vessels becomes blocked. So really, tension pneumothorax is one of them. What are signs and symptoms? What are late signs and symptoms of tension pneumothorax? Tracheal deviation, hypotension, ABD, all that kind of stuff. So why do you have the tracheal deviation in tension pneumothorax? Well, what?
Because of that.
Yeah, because of that, the pressure, right? The pressure is pushing the whole mediastinum, and also that pressure is actually affecting your main vessels, right? Even if it was pushing the other way, it's going to, that increased pressure from tension is going to affect those main vessels right there. So that's going to affect preload, right? It's going to affect the volume coming back. So that's why you start seeing the hypotension. If we relieve this pressure through needle decompression, we should start seeing a rise in blood pressure. We should start seeing an increase in SpO2. We should see that mediastinal shift go back to midline. Pericardial tamponade. I talked about Beck's triad, muffled heart sounds, distension in jugular veins, and low blood pressure. The thing that needs to occur with cardiac tamponade is pericardial centesis. We're not doing that in the field. All right. So a couple of types of distributive shock. So distributive shock is going to be, distributive shock is not a pump issue, and it's not a vessel issue. It's a container issue. Okay? So with distributive shock, for whatever reason, the cup has gotten as big as the trash can, but the fluid has stayed the same amount. Couple of different reasons: septic shock, neurogenic shock, anaphylactic shock, psychogenic shock. I wish they wouldn't include that in there. With septic shock, sepsis occurs from widespread infection. So essentially the bacteria has now gotten into the rest of the system and now is producing inflammatory chemicals. A subset of sepsis in which underlying circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than in sepsis alone is when you get a septic shock. Clinical criteria include hypotension requiring the use of vasopressors. So in septic shock, they will use vasopressors to maintain a MAP of at least 65 and having a serum lactate greater than 2 millimoles per liter, persisting despite adequate fluid resuscitation. Widespread infection. Septic shock is pretty complex. So there's actually a distributive shock and a hypovolemic shock aspect to it, because you got a leaky container that starts having the fluid shift out of the container into the interstitial space. Also, it will go into the respiratory system, where you're going to start you'll start seeing ARDS. You'll see septic shock in ARDS. You'll see ARDS in septic shock a lot, and as that septic shock progresses, you'll see MODS as well. All right. Patients usually have warm or hot skin. Why do you think they got warm or hot skin if they're in septic shock? What? Fever. Because of an infection. But septic shock, that patient can be either hypothermic or hyperthermic. All right. So they may have a blood or a core temperature of less than normal, or it may be higher than normal. Septic shock needs quick treatment. If you got a patient that is in septic shock, give hypotensive patients dopamine, or if you're at a system that uses Levofed, like in LaGrange where Steve works, they use Levofed. Levofed's actually preferred over dopamine for septic shock. Epi for warm shock. That's if they're warm, and norepi, which would be Levofed, or epi for cold shock. Conserve body heat, fluid boluses. All right, neurogenic shock. So neurogenic shock is a communication issue. What do I mean by that? A communication issue. What usually does it come from? A spinal cord injury, right? What does the spinal cord do? It transmits nervous impulses to other parts of the body, right? So if you have a spinal cord injury, what's going to quit communicating below that injury? The brain, right? The nervous system. So now below that area, you're going to start having a incomplete communication, and so it's not going. The vessels are not going to get the signal whether they need to expand or contract a distributive issue again. So they're just going to lose all sympathetic tone, and they're just going to open up. Right? All vessels below the level of the spinal injury dilate. The patient experiences relative hypovolemia, leading to hypotension. Relative bradycardia occurs. Skin is baseline color warm and dry because of cutaneous vasodilation. So this is not your normal, I'm going to shunt from the rest of the body shock, right? This is a communication issue, so the skin hasn't gotten any signals or anything like that to actually shunt. So we're still going to have normal skin feeling, at least for a period of time. Epi and norepi are not released, and so they're not going to get that communication. They're not going to get the news to contract, and then the patient also won't sweat below that injury. Spinal shock occurs after a spinal injury produces motor and sensory losses. This is where they're going to have flaccid paralysis, flaccid sphincters. So what happens when sphincters get flaccid? They don't stop the fluids they're supposed to, right? Absent reflexes. So basically, this is when they're paralyzed, right? Level of injury is related to the severity of shock. Damage to the spinal cord may cause injury to the autonomic nervous system, and then swelling and edema of the cord will begin within 30 minutes after an insult. Then also secondary cord injury develops over the first few days. Have y'all ever heard of people that had spinal injury and they were able to walk afterwards, but then a little while later, like they lost function? That happens because of the inflammatory process. Level of injury to the cord is related to the severity of neurogenic shock development. Injury above the T1 level can disrupt all the spinal tracts that control the entire sympathetic system. Injuries from T1 to L3 may partially interrupt sympathetic outflow. The higher the injury, the more likely spinal shock will develop. Care for neurogenic shock is similar to general management. Determine the necessity of IV fluids based on hemodynamic status. We want to keep the systolic pressure at 90. Boluses of 20 mL per kg increments, 2 liter via large bore IV catheter. Use warm fluid to prevent hypothermia. There you go. All right. So, what's signs and symptoms wise? What's different from neurogenic shock versus regular shock? What you drinking back there, Cole? I just looked up and saw you turning one up, and I'm like, dang, dude. Man, I know that this is bad, but it ain't bad.
First day.
What did I tell you the skin's gonna feel like? Warm. Skin is usually cool and clammy in normal shock, later term. What about heart rate? Heart rate may be normal to lower in neurogenic shock. What about blood pressure? It's going to be a little bit low, right? What's anaphylactic shock?
Violent reaction to a substance which a person has been sensitized.
Absolutely. Good job. All right, so anaphylactic shock is going to be just a violent allergic reaction, right? It's a systemic reaction to a stressor, okay? What does it mean to sensitize? That means the developing a heightened reaction to a substance. Subsequent exposure after sensitization produces a more severe reaction. All right, so think with me if you will. My body has never eaten pork rinds before. So today, I start eating pork rinds. whatever reason, the IgE, immunoglobulin E, and the other products of the inflammatory response decide that I hate pork rinds. So my body has now made a pact with itself. It has made a suicide pact that says if we ever eat pork rinds again, we're going to do everything we can to kill ourselves. I mean, that's what happens, ain't it? You got to be sensitized. I mean, it's what happens, though. And so essentially, once we have been sensitized to it, the body decides, oh, I don't like that anymore. Whatever, it's usually it's a protein that our body just doesn't react well with. And so then we're going to start having these chemicals released. Now we'll get a lot more into this when we do immune stuff, but a lot of chemicals are released. An antigen is in our body. Our body develops memory to that antigen with antibodies. If the antibodies are released, but in that process you also have what's called histamine. Y'all heard of histamine? And leukotrienes, which are released. The histamine causes vasodilation. So does the leukotrienes. Also causes bronchial constriction. Also, fluid leaks out of the vessels into the interstitial space. You ever notice that when somebody's having an allergic reaction, they start getting puffy and swollen? Because now we've got leaky vessels. So now we've got distributive shock and we've also got hypovolemic shock. Now this is a picture of somebody with angioedema. And angioedema is when like the airway areas, the tongue and all that, they all swell due to an ACE inhibitor is typically what causes it. But what's your main management for anaphylactic shock? What's your mainstay golden treatment for anaphylactic shock? Epi. Right? If they're starting to have any signs of anaphylactic shock, whether it is airway difficulty or hypotension, altered mental status, signs of upper airway constriction, stridor, we want to give epi. As a matter of fact, anaphylactic shock is probably going to be one of the conditions that you probably would give the most drugs out of your drug box if you went and treated the whole thing. One, well, what are you giving an anaphylactic shock? Well, we're going to give epi, right? We're going to give fluids. What else? Benadryl, albuterol, maybe Atrovent or ipratropium. Yeah, steroid of some type, Decadron, Solumedrol, something like that. What if they are sick at their stomach? We might give some Zofran or some type of antiemetic, right? I mean, that's 7 drugs right there that you might give. What if you have an anaphylactic shock patient and the doctor orders you to give epi IV? Can you do that? Yes, but it has to be 1 to 10,000. Yeah, it's got to be a 1 to 10,000, but you can't give it IV in anaphylaxis. You got to make sure it's a 1 to 10. You can't give a 1 to 1,000 because that'd be a lot going through that vein, right? Now our 1 to 1,000, we're going to give IM, but we got to support the cardiovascular system. But the main way that we can support everything is epinephrine. All right. Psychogenic shock, sudden reaction to the nervous system that produces a temporary vascular dilation resulting in syncope. Could be life-threatening causes such as irregular heartbeat or brain aneurysm, but typically is caused by a DFO episode. Okay. Nobody's going to ask.
Yeah, what is it?
Done falled out. Also, in some areas, known as a "Oh Lordy Jesus" episode. All right. Hypovolemic shock, non-hypo or non-hemorrhagic hypovolemic shock, fluid loss out of the container, We can give just normal saline or some other type of volume expander. We want to look for signs of dehydration, weak and rapid pulse, rising more than 15 beats per minute when the patient is raised from a recumbent to sitting position. Talked about the fluids. If the patient vomits, if they're hypovolemic, the patient vomits, we might want to give an antiemetic. Consider administering 20 ml per kilogram in 250 milliliter boluses. Checking blood pressure after each bolus. If it's I'm just going to go off record here, but if it is a hypovolemic shock due to like dehydration, nausea, vomiting, you can give them as much fluid as you want to. That's what they're going to get at the hospital. Okay. All right. So make sure we're not getting fluid overloaded when we're giving them fluids back. But if you can feel a pulse over the femoral artery but not over the radial artery, the systolic blood pressure is between 70 and 80. Medical control may order sodium bicarb to treat acidosis. I've never seen that in hypovolemic shock in the field. Or vasopressors. Don't wait for the blood pressure to fall before suspecting shock and starting treatment. The goal in treating shock is to save the important organs. Okay, the brain, the lungs, and the kidneys. Respiratory insufficiency, the inability to breathe, inadequate amounts of oxygen affects the ventilation process of respiration. Just briefly talk about this. Do y'all remember talking about a VQ mismatch?
Yes.
So this is going to be an issue with either the pipes or the circulation. Okay? So it's either a ventilation issue or it is a perfusion issue. And it could be caused by some poisoning issues or acidosis, anemia, chronic or acute bleeding, deficiency in vitamins or minerals. What we're saying here, what basically they're talking about here is the fact that not everything respiratory-wise is going to be because of asthma or because of a blocked airway or something like that. It could be as a result of an anemia or some type of perfusion issue. Okay? So transportation of shock patients. Ask yourself when, where, and how. Try your best to limit scene time to 10 minutes or less. And don't be afraid to call the helicopter if you need to. Transport to a facility with appropriate capabilities. If not available, medical control can help make a transport decision. All right.